Good afternoon. Can everyone hear me?
Yes, I can.
Wonderful. Well, I want to welcome everyone to our virtual Family Council meeting. My name is Sherry. My role is Family Council and Volunteer Coordinator for the State of Idaho Long-Term Care Ombudsman Program. We will be hosting these meetings on the fourth Wednesday of every month. We host these meetings to empower and educate families and residents on all aspects of long-term care. Please note, these meetings will be recorded and uploaded to YouTube. Simply Google Idaho Virtual Family Council and you can easily locate them. We'll begin with our presentation, and then at the end, we'll open our meeting to questions. All of our monthly meetings use the same Zoom link and the same QR code, which makes it very easy to find. Please join us on all of these meetings. These forums will have a lot of important and very meaningful information, and please share our information to others so that they can join and participate. But before we get started, let me go over a few things. We have a confidentiality reminder. Please refrain from using your name or the name of your loved one, and please don't name specific facilities. Please use the term nursing home, assisted living, or personal care home to present to the group. If you need specific assistance, please use the chat feature to state the county that you are in, and we will have an ombudsman reach out to you. The calls have public access and are designed for family members, as well as residents and friends of residents in long-term care. Few housekeeping tips. You've all been placed in mute upon entry. We'll open the lines in a bit so that you're able to ask questions or speak. If you would like to speak or have a question, please use the raise hand feature. Once we've completed our presentation, we will open the meeting to questions. The chat feature is also available at the bottom of your screen. Once you maximize it, you'll be able to ask questions to the chat moderator or others during the call. If you have any concerns or complaints, they can be directed to the state ombudsman, and I will post this again at the end of our meeting. Today, we have a speaker from the Alzheimer's Association, the Greater Idaho Chapter, and I'm going to go ahead and give this to her and let her introduce herself. Katya, are you on?
Yes, I'm right here. Thank you so much for the introduction.
You're
My name is
welcome.
Katya. I volunteer with the Alzheimer's Association. Just a little bit about me real fast. I facilitate a support group for caregivers on the last Monday of each month at our local Nampa Public Library. And there are several other support groups across the valley each month in case anyone here is interested in those. I also do little community outreach presentations such as this, typically in person, but I'm so honored to be hosted today on Zoom. And I'm going to be presenting a portion of our Empowered Caregiver series entitled Responding to Dementia-Related Behaviors. So let's get started. Mercedes, are you ready with the slides? Excellent, excellent. Can everyone hear me okay? I also should probably make sure.
Yes.
Excellent.
Yeah.
All righty. So, like I said, this is a portion of our Empowered Caregivers series. We have our local office here in Boise, and if there's any questions that I do not touch on today, we have so many resources offered by them, and they are always a good place to start. This program today is going to be for caregivers who want to learn how to communicate well with their loved one who is living with Alzheimer's or a related dementia disease. Today, we're going to have some videos of real caregivers as well as some experts commenting as well. And while though I'm not one of those experts, I am also so willing to take questions. And so if you would put them in the chat, please, I will get to them at a few good stopping points throughout our presentation today. Let's get started. Next slide, please. And one more. Sorry. So today, let's look at some learning objectives before we get started. After this program, you should be able to describe how dementia can indicate changes or can cause, changes in somebody's behavior based off of a need not being met. And a lot of times they are just evidence of something triggering the individual and they're not able to necessarily express it verbally. We're also going to be comparing some non-medical and medical ways to address these behaviors. And then we also have a 4-step approach for managing these behaviors. Next slide, please. Sorry, next slide, please. So these dementia-related behaviors can be just a good way of noticing that something isn't right with your loved one or a need is not being met. So it's kind of like an alarm bell going off, especially if these dementia-related behaviors are especially out of character for the individual. It's really important to react in a calm and loving way because oftentimes, most of the time, these individuals don't even have really control over these behaviors, and they will have good and bad days. And so it's just important to take each step at a time. Next slide, please. So what can cause these behavioral changes? The main reason that the individual will start having these personality changes as their disease progresses is because Alzheimer's and related dementias do cause the degeneration or the breakdown of neuron cells. And so these brain changes make it harder and harder for the individual to understand the world around them. And so they begin reacting in whatever way feels adequate in the moment. And it might not even be something real and tangible going on in front of them. So we really have to focus on being attuned to our loved ones' usual behaviors and then being able to compare and contrast those with what may be dementia-related cues. Next slide, please. We're going to hear from an expert today about some of these behaviors and what they can indicate.
The changes in the brain that occur with Alzheimer's and other dementias then can impact on somebody's cognition, their functioning, and also their behaviour. Now, these changes aren't consistent over time, but they can vary. They can vary day by day, and then they can also vary as the disease progresses.
Individuals living with dementia can have trouble understanding the world around them. And unfortunately, that could lead to them not knowing what's real, what's safe, or what's appropriate. That uncertainty then sometimes leads to dementia-related behaviors.
Next slide, please. So these behaviors are a form of communication, and as these diseases progress, the individual may end up having a harder and harder time expressing their thoughts, feelings, and emotions in a standard verbal way. And so all of these different behaviors we're going to talk about today are just ways for them to express how they're feeling when words aren't available, perhaps. Next slide, please. So these behaviors will more than likely make perfect sense to the individual living with dementia. And it's our job as caregivers to kind of decode those and understand what they're trying to tell us with these behaviors. It's really important to understand also that the behavior isn't necessarily, and most of the time, not at all related to how the person feels about you as an individual. And so it's really important that we don't take these behaviors personally, especially when bordering on aggression or anxiety related behaviors. Next slide, please. Here's a few common categories of behaviors that will occur, and a lot of them do overlap. For example, the anxiety and agitation that an individual with dementia ends up experiencing can often trigger the wandering that is so characteristic of these diseases. They might start looking for something that they don't even know what they're searching for, or they might keep saying that they want to go home, and they might keep trying to leave and going out the front door and not even having anywhere to go. This can then progress into aggression or anger, especially in individuals that are beginning to lose the memory of their loved ones, the people around them. And so they might see somebody in their home and not recognize them. And of course, I mean, I think we would all be a little bit agitated in that regard. And so it's always important to try to join the individual's reality and just try to quell them without making their whole world crashing down. Especially because another one of these characteristic behaviors can border on suspicion or delusional thinking. They may forget where they placed an object and think that someone is stealing from them. They might just have trouble remembering what happened and not believe you when you tell them. There's a lot of different manifestations of these. And like I said, it's just very important that we take each situation as its own individual task and really analyze what they're trying to tell us with these behaviors. Next slide, please. Now we're going to hear from a caregiver who has experienced one of these dementia-related behaviors for herself.
My mother did experience some degree of suspicion, and this is a rather long and involved story, but my name is Freddie James. My father's name was Fred James, and shortly after he died, my mother accused me actually of stealing some money, of going to the bank and actually using my father's name and my name, the similarity, to take some money, which absolutely had not happened, but this suspicion had developed in her mind. It took a lot of patience. It took a lot of explaining, but eventually it just took letting the situation die down, not getting too involved in it myself. In other words, not reacting in anger, not reacting with a lot of emotion, but just allowing her to work through the process.
Next slide, please. So we're going to take a closer look at these dementia-related behaviors. But before we do that, let's do a quick little knowledge check. So I ask that you all put your responses in the chat for me, and then we will see if we got them right. So our first question is, wandering only happens in the early stage of the disease, true or false? And if you don't know, guesses are more than welcome. We love guesses. Alrighty, let's see what our answer is. Next slide, please. Everyone got it right. It is false. Wandering can happen at any stage of the disease. In fact, 6 out of 10 individuals with Alzheimer's will wander at some point. We had another question. Guess not. Alrighty, we're going to talk about a few triggers for these dementia-related behaviors. So these are going to be things that can cause or exacerbate a behavior. They can be physical, social, environmental, or personal triggers. There are external triggers, so the first 3 categories I just mentioned, and these are going to be outside stimuli that can incite an uncomfortable feeling of some sort that will then trigger a dementia-related behavior. So first off, physical. This could be an injury or an unrelated medical condition, or even a drug interaction or a drug side effect that could be making the individual feel some type of pain or otherwise discomfort that can make them not even be able to describe how they're feeling, but they don't feel good. And so they will show us in other ways, and these will manifest as some of the dementia-related behaviors that we have previously mentioned. There are also some social triggers. This could be anything from the conversation being had or the individuals directly surrounding our loved one with Alzheimer's or another dementia. And this person might just get thrown into a social situation that is overly stressful or otherwise overstimulating to them. And so we really want to be conscious of who we are bringing our loved one around and whether they're actually comfortable to be in that social of a setting. The other external category is environmental triggers. And so this can be anything from the temperature in the room. They could be too hot or too cold. It could be too loud for them, kind of bordering on social. Another physical trigger that I failed to mention was look at what they're wearing. Maybe they're wearing a scratchy sweater that makes them uncomfortable or making them overheat. Or perhaps they need to go to the restroom and they don't even know how to relay that message to us anymore. We really have to be progressively more and more attuned to our loved ones' needs as their disease progresses. Last but not least, we also have personal triggers. These are going to be internal triggers. This could be emotions they're experiencing, or even anxieties that may or may not have been present before the manifestation of their dementia. Next slide, please. It's always good to start off with some non-medical approaches to coping and regulating these behaviors. So we're going to look at those first. Next slide, please. So there are medications that can help with some of the behavioral symptoms of Alzheimer's disease, but we like to try to mitigate the severity of them with non-medical formats first, because like we were saying, a lot of them are often triggered by the person's environment or otherwise their surrounding elements, and we can mitigate that. So we always want to have the approach of giving emotional and physical comfort. And this would be especially helpful in family members and friends when we're able to really know the person's typical behaviors and decode what is abnormal. So we really need to keep in mind their needs, their interests, likes, dislikes, viewpoints, preferences, abilities, whatever you think the standard that they used to enjoy, we need to try to uphold that. So if they're typically a little bit running on the cool side, make sure they've got a blanket, make sure they're dressed in a sweater. They might not be able to relay those things verbally to us as their disease progresses. Next slide, please. So I mentioned we have a 4-step approach at the Alzheimer's Association for addressing these behaviors. And so it can be hard to understand why an individual is beginning to exhibit these behaviors. But the more that we're able to understand where they're coming from, the more we're able to support them. Next slide, please. Alrighty, so our 4 steps. Number 1, we've got to detect and connect with the individual, detect the behavior and connect with them and see why this is happening. Then we're going to take care of their physical needs before anything else, prior to moving on to emotional needs, and then kind of reviewing and revising our plan for next time so that we maybe can zero in on the particular issue at hand quicker next time. Next slide, please. All right, detecting and connecting. Step number 1. This goes back to that concept of joining the individual in their reality that we were talking about. So we need to try to look at the world the way that our loved one with dementia is seeing the world. So connect to them as they are, and we need to do our best to see what they're trying to communicate to us. We're going to approach them calmly, quietly, and respectfully always. We are going to listen to them if they are verbally trying to express anything to us, and we're going to really try to figure out their situation from their shoes. We're going to avoid correcting them or telling them that they're wrong because they're just trying to relay to us how they truly feel. And it's their reality, so that it's true for them. Next slide, please. We're going to ask ourselves some questions in order to identify the need behind this behavior. We're going to ask, who was there when the behavior began taking place? And what had happened before and shortly after the behavior began? Are there certain times of day or locations where this behavior is more prevalent? Maybe we can narrow down the triggers that could be causing these behaviors. And then we also always have to look back at ourselves and see how we reacted when this behavior onset. Next slide, please. Next, we're going to take care of their physical needs. All right. So we're going to always start by just kind of looking around and assessing the situation to see if there are any obvious medical issues or other physical pain-inducing problems going on. The individual could have fallen when we weren't around or earlier, with a different caregiver, or they could even have an underlying medical condition that hasn't been diagnosed yet. Something I always like to bring up is with the direct caregiving that I gave to my grandmother, we discovered that inadvertently, actually, urinary tract infections, once they progress enough, they can have memory-related and cognitive-related symptoms associated, kind of as collateral. It's very interesting, actually. And I feel that more people should know to watch out for UTIs especially in dementia patients, because they can cause this increased brain fog, disorientation, and just kind of a seeming worsening of symptoms that can be completely unrelated to their dementia disease. It could absolutely be a progressed UTI that then, once it subsides with the correct course of antibiotics, you will notice that their brain fog and associated symptoms will greatly decrease. So I always like to point that out and make sure people are on the lookout for those. Here's a few ways to identify and take care of the individual's personal needs. Like I was saying, we're always going to look out for uncomfortable clothing, some things that we might not notice. Maybe their waistband is rolled down and they're just so uncomfortable and they just can't figure out how to fix it. We have to be there for them. And it might be something as simple as that. It could also be anything from lighting in the room temperature, hunger or thirst, a need to get up and move around that many caregivers might overlook. We all gotta get up and, just kind of stretch everything out, get that blood moving. The need to go to the restroom, or sitting in an uncomfortable position and not able to comfort their own selves, or even just too much noise or activity going on. A lot of Alzheimer's and other dementia patients can get very easily overstimulated. So once we've assessed the situation, we really want to make any changes we're able to ensure the comfort of our loved one. So we're going to also share any signs of physical pain or otherwise perhaps disorder-related symptoms with the individual's medical care professional. Next slide, please. Step 3 is going to be helping with emotional needs. So we really want to think about how the individual is feeling at the moment, especially with certain dementias. There is a tendency to have very frequent mood changes, and they could be triggered by external factors or not. And so we really just want to ask them if we're able to, or just analyze by observing whether they're anxious or tearful, or any kind of external signals that show us how this individual is feeling. We always want to be there to offer comfort and let the person know that we're there and that they're going to be safe with us and that we're trying to make them more comfortable. We also love knowing or love using what we know about the individual's likes and dislikes in order to kind of redirect their energy into something else, something that gives them joy typically, or maybe they're just able to get their mind off of the issue if it's not something that's able to be mitigated in the current moment. And sometimes none of that will work, and that's totally okay, and it's totally normal. And sometimes the best decision is to let it go and approach them at another time and try to fix it at a later moment. We can't force them to be responsive to our soothing and our consoling. And so sometimes we just need to give them some space. Next slide, please. Last but certainly not least, step 4 is going to be revising, reviewing, and planning for next time. So we're going to go back to that detect and connect step, and we're going to wonder what went well and what didn't. How can we change our responses in the future? How can we be more attuned to the individual's external cues of their emotions or physical discomfort? And we need to know that this type of issue very well could and probably will come up again. And so we need to kind of almost create like a checklist for ourselves of what we can use as warning signs or preventative measures. We also need to keep track of what responses work well and what order maybe we need to try those responses. Next slide, please. So next, we're going to see some real life examples of this 4-step approach at responding to the dementia-related behaviors. For each one of them, we're going to see one portion of the 4-step program in action. We're going to start with anxiety and agitation. So here's a few situations that could be triggering for some internalized or externalized anxiety and agitation symptoms or behaviors. We could be moving to a new residence, perhaps whether a care facility or just a new home, a new family home. It could be a different change in the environment. Perhaps the individual had to get hospitalized or had to go on a trip or has new individuals staying in their home. Any break in routine for the individual dealing with dementia is going to be a significant upheaval in what they're used to, and that can definitely incite a stress response. They might, in general, just feel afraid or tired of trying to make sense of the world around them. Next slide, please. So let's see in this scenario how we can use step 1, detecting and connecting with the individual experiencing anxiety. Eugene is living with dementia. He lives in a quiet apartment with his daughter, Denise. Eugene spends most days in the living room doing jigsaw puzzles. Denise's sister and her young children visit from out of town. Kids are noisy and running around the apartment. Eugene looks anxious and does not want to come out of his room. So based on this scenario, how do we think Denise could detect and connect with Eugene? Next slide, please. We have the following 4 options. We've got 1, try to see the situation from Eugene's perspective. 2, we could think about when Eugene's behavior started, what incited it. 3, we could consider if having noisy young children in the apartment is making Eugene feel anxious. Or 4, we could get angry and assume Eugene is just being difficult. Go ahead and put the numbers that you think are correct in the chat, and we can talk about it. Alrighty. Well, I can tell you that it's 1, 2, and 3. Joan got it right. Good job. Yes, so we really love to avoid any kind of hostility, despite how frustrating sometimes it may be to try and figure out someone's behaviors when they're not telling us concretely what is going on. If you need to take a breath, walk away, come back later, that is always the better choice. Apart from that, we can definitely see how the noisy children visiting the home could incite a stress response in Eugene, especially if he doesn't even maybe remember whose children these are. I think that might stress anyone out. Next slide, please. Righty. We're going to check out how we can mitigate aggression and anger using step 2. So some situations that can trigger aggression can, again, be anything from physical discomfort, hunger, sitting in an uncomfortable position, needing to use the restroom. It could be environmental factors. It could be a lot of noise, just like what we were just talking about, or the temperature, or even just poor communication. There are forms of dementia, such as frontotemporal dementia with the aphasia variant, aphasia is the inability to continue decoding language the way that our brains were trained when we learned the language. And progressively with specifically the frontotemporal dementia, a lot of people end up having problems articulating their feelings or even understanding what others are saying to them. So when we talk about poor communication, it could really just be this person is externally presenting their internal frustration at their own disease progression. Next slide, please. So we're going to see how we can use step 2, taking care of the individual's physical needs in a real life situation where, in this case, Sonia is living with Alzheimer's. She lives with her son, Hector, who hired a home care aide to help with Sonia's needs. Recently, Sonia has been yelling at the aide during bath time. Hector recalls the aide telling him last week that Sonia fell while getting out of the bathtub. Hearing this real life scenario, what do we think we could do to analyze her behavior and see why Sonia feels such aggression towards her caregiver? Next slide, please. So how can Hector take care of Sonia's physical needs first? And how can we address her aggression? We can check for any injuries from Sonia's recent fall in the bathroom with that caregiver. We could talk to Sonia's doctor and ask the doctor to check for any injuries. We can also consider hiring a different aide to help with Sonia. What do we think? Place your answers in the chat for me. Anyone else? Alrighty. Daphne, I would agree with 1 and 2, but unfortunately not 3. This is a situation where it would definitely be wise to try the other 2 tactics listed here first, prior to assuming that we need a different aide or different caregiver, because there are a lot of situations where the caregiver genuinely may not be at fault, and it really may be more of a trauma response than anything. We were told that Sonia fell in the shower a few weeks ago, and so there's a very good chance that maybe even if she doesn't remember the fall itself, her mind is able to associate the bathroom and that caregiver with a setting related to danger or pain. And so we really want to consider all those options prior to assuming that we need to switch care. Next slide, please. Alrighty, next, we're going to see how we can use step 3, addressing the individual's emotional needs when it comes down to behaviors related to suspicion and delusional thinking. So some situations that could lead to this is, for example, the individual living with Alzheimer's or another dementia finds their wallet empty, or they think they recall placing a certain object on the table, and then they come back and it's not there because they don't remember that they moved it. Or even a caregiver moves something because they have what they would consider a stranger living in their home, and they might not even remember that sometimes. We always need to really put ourselves in their shoes and see what might be scary or angering for the individual at a given moment. Next slide, please. So in this real life scenario, we've got Clara, an 85-year-old living with Alzheimer's disease. She's living with her daughter, Irene. And so recently, Clara has been nervously walking around the house. She's been looking out of all of the windows in the afternoons and telling her daughter, Irene, those people are out there again. They came in here last night and took my purse. Irene, her daughter, tells Clara that no one has broken in and that her purse is still in the closet. However, Clara keeps walking around the house and becomes progressively more upset. So we're going to look at how her caregiver, Irene, can use step 3 to respond to this situation and try to quell those suspicions and delusions. Next slide, please. All right, so Irene could A, distract Clara by asking her to set the table for dinner. 2, Irene could assure Clara that she is safe and offer to check that all the doors in the house are locked. And 3, Irene could listen carefully to Clara's accusations and say that she has taken the problem seriously. Go ahead and put in the chat what we think is the right course of action. All right, 2 and 3. Fanny got it. Great job. We really do want to join the person's reality. That is a great first step in, honestly, any of these potential scenarios, because it's always better to try and support and calm the person in the situation that they find themselves in, rather than trying to convince them that it's not actually happening, for example. Next slide. Alrighty, and last but not least, let's see how we can use step 4 when an individual is having a tendency to wander or even get lost. This could happen for a variety of reasons. This could be a coping mechanism to a sense of pain or discomfort, or just overall restlessness or anxiety associated symptoms. They could feel bored. They could be looking for something to do. They could just want to go for a walk and not even know where they're going. Or they might still have an unmet need, such as hunger or needing to use the restroom, and they might be unconsciously looking for that. Next slide, please. Fourth and final real life scenario, we'll examine how we can use step 4, which is reassessing and planning for next time after the individual has experienced a wandering episode. So, Mai Ling is 69 years old and living with Alzheimer's disease. She lives with her son, Kenji, his wife, and their 2 young children. Mai Ling ran her own flower shop before she retired. Kenji starts to notice that Mai Ling walks back and forth when she is in the yard and seems anxious. Once, she tried to leave the yard when the family was outside with her. She tried to go into the neighbor's garden. Next slide, please. So, one more time, I'll have you put in the chat what we think Mai Ling's family can do to plan for the next time that she tries to wander like this, because they are worried that she is going to try and leave the yard again. We can stay connected with Mai Ling while spending her time outside, supporting her with some simple activities to reduce boredom. We could avoid taking Mai Ling outside to spend time in the yard at all. We could make the yard more attractive to Mai Ling's interests. We could plant flowers she likes or decorate the yard with items that could be found in her garden. Or we could tell the neighbor about Mai Ling and her situation and then let her know that she's interested in their garden due to her former career. And maybe we could just give the neighbor the family phone number so that they can call if they ever find Mai Ling checking out her garden again. You guys beat me to the chat. And ding, 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 everyone got it right. We're going to go with 1, 3, and 4. We really do want to not restrict the individual unnecessarily. So if this family seems to have a fenced-in yard, yes, with a gate that apparently Mai Ling is able to operate, but I really do like the idea of giving the neighbor the phone number. We really don't want to keep her from using the yard. She seems to get a lot of enrichment out of it, as do all people. Time outside, time in the sun, time in nature is very important and very enriching. And we really do want to give them that change of scenery. You know, it gives them something to prevent boredom, which could be a trigger for wandering in the first place. Next slide, please. Now we're going to hear from a caregiver expert.
While caregiving for my dad, I realized that one of the behaviors that he had related to his dementia was wandering. He would often feel restless and want to leave the house, sometimes at 5 in the morning, sometimes at 8 o'clock at night, or just at any point throughout the day. And at first I was very frustrated by this behavior and just would constantly tell him, "Dad, you can't go out right now. We're not going out right now." But I realized over time that that was not working. And rather than telling my dad what he couldn't do, I had to put things into place, telling him what he could do, offering him a structured schedule, activities that were not overstimulating, and a schedule that really promoted him feeling calm and engaged throughout the day. Once I started doing this, it really helped to reduce the wandering.
Alrighty. So, as we were saying, most of these dementia-related behaviors are a result of their respective disease progressing. Oh, next slide, please. And so it's really important to know that these can also be triggered by a critical medical need of some sort, related or unrelated to the dementia. And so it's really important to consider those possibilities as well, especially if none of the previously mentioned tactics are working to mitigate the individual's behavior. Because we're not always able to help. It's always good to try, but if it doesn't work out, we always got to turn to a medical professional and see if there's anything else going on. This could be anything from drug side effects or weird drug interactions. There could be multiple prescription drugs that the individual is on that could be having unforeseen clashing side effects, for example. They could have an acute condition of some sort, like UTI, urinary tract infection, that I was talking about before. really could greatly cause anything from brain fog, increased disorientation to fevers, chills, kidney pain, and it could be a variety of other acute conditions as well. Also, there's a chance that their hearing or vision is going at an increasing rate. And so this can absolutely add to confusion and frustration because they're having a hard time hearing and seeing the world around them, which is only going to compound with their reduced ability to understand these stimuli that they're surrounded by. Next slide, please. So if you believe that there may be a medical problem causing any one of these behaviors, it's really important for a doctor or other healthcare professional to check the person out. Sometimes they may prescribe medications and sometimes they might not. This is always to reduce and control symptoms. We're not always going to need them though. Not all dementia patients will experience delusions and not all will experience the aggression or the wandering. And so every situation is quite different. We always want to discuss with the doctor any risks or benefits before proceeding with a updated care plan. Next slide, please. So I do have a worksheet for you all. Typically, this would be an in-person presentation. I would have passed them out already, but the lovely Mercedes has just put it in the chat. At your own convenience, you're more than welcome to examine it. I'm just going to talk about it real quick. So in the activity, you're going to read a story about Manuel, who is living with dementia, and his wife, Olivia, who is his primary caregiver. We're going to talk about how Manuel was trying to communicate something to Olivia through his behavior. And we're going to see how Olivia responded by implementing the 4-step process that we have just discussed. After that, you'll have an opportunity to think about your own loved one's situation and kind of analyze how we could also apply this 4-step approach. And we've got a few helpful guidelines and little bullet points along the way to help you. So I really hope that you all take some time to look at that. I found it to be very helpful in really understanding. What's that? I'm sorry, I missed that. What was that? Okay. Well, moving on. Sometimes we are not able to mitigate these behaviors or help the individual cope on our own. And there are times when additional help may be needed. And it is always important to know when that point has come. Next slide, please. These behaviors are definitely stressful for everyone involved. And so it really is going to depend how well we are implementing the 4-step approach that we are discussing. Also, it's important to note that these behaviors can and likely will become more severe as the disease progresses. And so it really can become increasingly hard to respond in a person-centered, individual, empathetic way, especially when it is someone close to us with that extra emotional aspect involved. And so there are times when we do need to consider finding either outside help or even moving the individual into a different type of caregiving setting. This could be if it becomes too much for your own personal well-being, which there's a huge, I could call it an endemic problem among caregivers that they put their all, we put their all, our all into caring for our loved ones to the point where we neglect ourselves so much that, one day the individual gets moved into a private care facility, a nursing facility of some sort, and the caregiver finally has time for themselves. And unfortunately, there's been a huge statistic of caregivers passing away shortly after either their loved one themselves pass away or get moved into nursing care because the caregivers have been neglecting themselves for so long. So I really find that's a big thing that I try to emphasize even in my monthly caregiver support groups, especially because there's not anyone caring for the caregiver. we need to care for ourselves. We need to be our own caregivers so that we can caregive for our loved ones as long as possible. Also, another reason to find outside help would be if anyone in your household is in danger of, or their safety is being threatened. Next slide, please. An especially important note, especially in our lovely state of Idaho, we have many firearms all across the state, and I find it incredibly important to just really emphasize how we should be locking those away, whether in a locked cabinet, a gun safe, or even moving them to another residence, because it doesn't matter if the individual was well trained in their youth or in earlier in life, whether they know how to operate a firearm well, whether they have always had safe habits throughout their entire life or not, or whether we think that they would never want to touch it. We could go the other extreme. It does not matter. Unfortunately, it's not a matter of trusting your loved one. It's a matter of not trusting the disease. We cannot. And this could cause a threat to the safety of not only our loved one with dementia, but also anyone else in the residence or in surrounding areas. So I always try to emphasize we really need to be preventing these types of accidents, preventing the scary Amber Alerts we get on our phones, and we really just need to be locking up those guns. I even have a box of trigger locks that I like to pass out at my support groups if anyone wants them. Next slide, please. So I mentioned a few resources that the Alzheimer's Association offers, such as our support groups and these community outreach presentations, but there is a boatload more at your disposal, and I really recommend that everyone visit our lovely website, alz.org, and just to explore and see if there's anything that could be helpful. We have online webinars as well as in-person educational programs. We've got kind of like a blog post type of site, ALZ Connected. We've got all kinds of tips, tricks, advice, help, all kinds of beautiful resources on the internet, as well as our lovely 24/7 helpline, which is staffed with master's level clinicians that are available 24/7, 365, whether you need to vent, cry, ask questions, laugh, anything you need, they are there for you. Any questions? Thank you so much for having me. I'm so honored.
Thank you, Katie, for a great presentation from the Alzheimer's Association. Information is greatly appreciated. Thank you for your time.